The next topic is about the migraine, headache in general and migraine in specific. Now, headache is one of the very common condition which everyone meets, and in the clinical practice, it is also it's one of the major headaches. And related to headache, there are a lot of activities, and probably among all the disease-related societies, International Headache Society and American Headache Society are very active, and lots of researches are going on, and lots of information about the headache and the conditions are presented. Probably among all the disease entities, this is one of the disease entity where the society acts in a very huge, very active manner. Anyway, that's the other issue. Now, headache as such is a very complex issue from the clinical point of view. It's a classification of the headache itself is a big headache, and the classification as per the International Headaches Classification, third edition, the headache is categorized into two categories: primary and secondary headaches. Among the primary headaches, migraine is the one, then tension type headache, trigeminal autonomic cephalgias, and other primary headache disorders. But our interest, because we are discussing about the neurological disease, we will limit ourselves to migraine and the trigeminal neuralgias. Other conditions we will just leave it as such. Maybe in due course of time, whenever we discuss other issues, we may come across these issues. Then the other condition, of course, we also would be discussing about the cranial neuropathies, the other parts as such. Then headache attributed to trauma or injury of the head, and headache attributed to cranial or cervical vascular disorders, headache attributed to non-vascular cranial disorders, headache attributed to substance or its withdrawal, that's a drug addiction or the withdrawal of the addiction, headache attributed to infection, headache attributed to disorders of homeostasis, headache or facial pain attributed to disorders of the cranium, and headache attributed to psychiatric disorders and cranial neuropathies. These are the classification. Comparatively, the classification mentioned in Ayurveda also is quite elaborate. There are 11 types of the headaches which are mentioned as Vataja, Pittaja, Kapaja, Sannipataja, Raktaja, Kshayaja, Krimija, Suryavarta, Anantavarta, Ardhavabedaka, Shankhaka. These are the 11 types of the headache mentioned in as such. Secondary headaches classified by the International Headache Society is slightly different from the headache generalized classification, third edition classification. The secondary headaches are classified as a head trauma, vascular disorders, non-vascular disorders, and substance use induced condition, non-cephalic infections, metabolic disorders, and cranium and neck ear eye disorders, cranial neuralgia, psychiatric disorders, etc. Migraine as such, our interest, because we are focusing on migraine, we will limit ourselves to migraine now, and other headaches will just leave it as such. Migraine itself is a very complex issue from the clinical point of view, and the classification of the migraine and coding itself is very elaborate, and that itself becomes a headache. But we will not go into all that complex issues. We will make it very simple. We will discuss only the migraine with aura and without aura, and cluster migraine or cluster headache. These are the only three things which we will discuss. Other categories, of course, not much of a significance from the clinical point of view. This would be from the academic point of view, like you will have lots of variations from the point of coding and clinical, maybe academic point of view. So we will not go into that much of the detail. So categories of migraine as mentioned in the coding, in ICD coding, would be huge numbers, which we need not bother much about. We will leave that detail. But my purpose of referring to this issue is just to show you the complexity of the literature about the headache. Now we'll directly jump into the migraine. Migraine is defined as a complex recurrent headache disorder. That's one of the most common complaints in the medicine, and the global prevalence of migraine is estimated to be 14 to 15%. 14 to 15% of the population is supposed to have a migraine, and accounts for 4 to 4.9% of the global disorders, measured as a years lived with the disability or disability burden of the disease, or disease burden as such. In India, the age standardized 1 year prevalence of migraine is 25.2%, and it's greater among the females than in the males, and it's also more in the rural areas. That's the statistics from the incidence Indian point of view. The global disease burden or burden of the disease, it also says the same. According to that 2017 data, the 1.3 billion individuals have the migraine. So number of patients having the migraine is quite huge, and very interestingly, the incidence of the migraine is increasing compared to 1990 to 2016. The raise is quite huge. The estimated years of patients lived with the disability of migraine have increased by around 51.2% from 1980 to 2016, from 29.8 million to 45.1 million. So number of patients with the living with the migraine headache are quite huge. And the other issues also related to the headache as presented by the WHO data is a migraine focused analysis of 2016 shows that migraine was prevalence of migraine was 18.9% in women and 9.8% for men. In the same analysis, the global age standardized prevalence of tension type of headache was 26.1%, again 30.8% in women and 21.4% in men. Of course, the incidence is highest in Italy and Nepal and lowest in China, though there may be a difference in the methodology of study. So that's not very confirmatory. Anyway, that's about the data. Now, as far as the pathology is concerned, migraine, earlier it was believed that migraine was considered to be a vascular phenomenon. In 80s when we were studying, the migraine was considered to be produced due to a vasoconstriction within the brain, or it could result in a rebound vasodilatation, and that vascular theory has mainly the three observations. One, extracranial vessels become distended and pulsatile during migraine attack. A patient, the vessels like carotid and other vessels, they seem to be more pulsatile, or even the veins also may become more seeming to be pulsatile. Patients may feel that impression, and the stimulation of intracranial vessels in an awake person induces headache. If somehow the intracranial vessels are stimulated, that induces a headache in a patient of migraine. And vasoconstrictors like ergots have improved the headache, and based upon this, and vasodilators like nitroglycerin provoke an attack as such. And based upon this, the vascular theory was established, and it was as such continuing for till a long years. But recent researchers have modified the definition or the pathology, and currently it is considered to be having a neurovascular theory. It's based upon a neurovascular theory, or it's a neurological condition, not the vascular alone, and it's migraine as a primarily neurogenic process where secondary changes in the cerebral perfusion associated with the sterile neurogenic inflammation. There is a inflammatory component of the nerves which results in the headache, and there is a under perfusion, reduced perfusion to the brain area. This is the current theory about the migraine as such. It's also true that migraine has a strong genetic component. Approximately 70% of the migraine patients have a first degree relative with a history of migraine, and the risk of migraine is increased fourfold in relatives of people who have migraine with aura. What is that migraine with aura? That we will come to that later. So that familial and genetic tendency for the migraine also is now proved. So there is another theory, is the genetic theory. The other theories, there are a lot of other theories. The other theories which related to the migraine now, which are now coming up, and they have some relevance in planning the management of the migraine also. There's a cortical spreading repression, some neurological activity getting reduced in some areas of the brain also is considered to be one of the theory. Another theory says that there is a migraine center at the base of the brain, at the brain stem. A migraine center is supposed to be there, and attempts to identify that migraine center and attempts to suppress that migraine center as a remedy also are being worked out now. Then the other issue is related to the dopamine pathway, then magnesium deficiency or vascular endothelial malfunctioning, serotonin pathway, We will not go into detail of each of these. So some biochemical medium, biochemical factors are also being now presented as the causes of the headache, or these are the theories of the migraine. One of the important observation is a acute overuse of symptomatic medication is considered as one of the most important risk factors for the migraine progression. So one of the very interesting and important issue is patients of migraine who are treated with the specific anti-migraine treatment. Among them, the anti-migraine treatment like triptans, which are very specific for the migraines, and the other drugs like opiates and barbiturates also aggravate the migraine, and they convert an acute migraine into a chronic persistent migraine. So this is a very interesting issue. The medicines which are used for the treatment of migraine can make the patient a migrainer, a continuous migraine or persistent migraine also. And it's now established like opiates which are used in a higher dose for 8 days per month. It may be increasing the chances of migraine progression. Barbiturates used for around 5 days per month also can increase these headache chances. Triptans, which are specific migraine therapies used for 10 to 14 days per month, can also increase the chances of the migraine. So that's a very interesting issue, and that's where our Ayurvedic treatment also comes to a role. Majority of the patients who come to Ayurvedic hospital would be of this category, where they are taking some specific migraine therapy, either any of these or maybe the other drugs, and the drug itself may be one of the triggering factors for the migraine, and withdrawal of that drug with our medicines can help the patients recover. Now, as far as the causes of the migraine are concerned, headache are concerned, from Ayurvedic point of view, the environmental factors and the habits of the patient and the emotional disturbances, consumption of the alcohol, and the living style, lifestyle of the patients, these are considered to be the causes of the headache. Consider dhuma atapa tushara ambu kreda ati swapna jagarehi utsvega adhi purovata bashpa nigraha rodhanehi atyambu madhyapanena krimibhi vegadharanehi upadhanam duja abhyanga dvesha adha pradatekshanehi. Continuous looking at an object with the eyes looking down, or something like the computer viewing or mobile viewing. Asatmya gandha dushta ama bhashyadesha shirogataha janayantyameyan doshaha. Now, as far as the current pathological consideration, pathophysiological considerations of the headache, as I told you, there are many theories, but certain of the established theories which have some relevance in the clinical practice are, there are the pathological process is categorized into the three mechanisms: the peripheral mechanism, then the central mechanism, and in the central mechanism again the patient expressing the pain, feeling the pain sensation felt. One of the theories, it starts with peripheral mechanism, where the external triggers, like could be like environmental factors and so on. I'll come to that list of the external factors, are as mentioned in Samhitas, like the emotional disturbances or maybe the environmental factors, cold, heat, etc. When it triggers the stimulation, peripheral mechanism, it reaches to the base of the brain and it produces a central changes of a increased tone of ascending pathway. The ascending nerves become more hyperactive. If they are not, activity is increased, then there will be no headache, no migraine. But if the tone of the nerve pathways, the activity of nerve pathways is reduced at that moment, it can result in migraine. Now, the areas which are specific related to the brain, migraine in the brain, they are categorized as thalamus and cortex, which are involved in the transmission of the pain inputs and perception of the head pain. The patient would feel the pain at the thalamus and the cortex. Now, these areas are important because among the remedies which are tried for the migraine, they are acting on these areas. If the thalamus and cortex, which can result in the acute pain sensitization, and the symptoms like photopenia or the aggravation or triggering due to the sounds in migraine patients, by depressing the thalamus and cortical activity by specific drugs, these symptoms can be reduced. So a symptomatic treatment is possible. The other area which is involved is hypothalamus, which when it is activated during the migraine, it gets activated during the migraine, and maybe the area where the migraine is a trigger initially. So if the migraine in the resting conditions and evoked activity of migraine, you can see the changes in the activity of the hypothalamus, and it also has a role to play with the sleep and wake cycle. So patients who have altered sleep patterns, the trigger mechanism is thalamus, and the thalamus, once it triggers, then the migraine symptoms would occur. Then PAS is the enzyme which is presented. It provides descending modulatory drive into the brain area, and it also can present with the SPB activity, a special migraine activity, leading to the cortex. And there again, certain of the drugs like triptans act at this level, which can reduce the symptom of pain. Then PONS, when it is activated during the migraine, it contains a salivatory nucleus which provides an autonomic input into the cranial vessels and interacts with the vessels, that the brain vessels. And vasoactive drugs act at this area, which can reduce the impact of the brain. And the primary efferent synapses of the trigeminal efferents and the descending inputs of the dorsolateral pons of the hypothalamus, these also can result in the headache symptoms. So these are the areas of interest in the brain which can result in the migraine. Migraine as such can be having a course of a prodromal phase, an aura phase, and a headache phase, and the postdromal phase. The different areas of the brain which are involved in these are: in the prodromal phase, the thalamus and hypothalamus have some basic activity or basic abnormality which can have an abnormal reactions whenever there is symptoms or clinical triggering factors like irritability, food cravings, mood swings, etc. Aura is due to the involvement of the cortex, and there in the cortex there could be this cortical spreading depression. The biochemical activity in the cortex would be reduced, and the headache phase, the peripheral nerves, particularly the trigeminal ganglion and trigeminal nucleus, they become activated, and meninges also becomes activated. In the postdromal phase, that's after the headache, the patient would have a feeling of reduced activity due to the activity of the brain stem. Now, all these put together, they summarize all that multiple theories about the migraine. Now, as far as the clinical factors, basic clinical factors are concerned, there are certain risk factors which aggravate the migraine conditions, and they are proved now. See, patients who have some inflammatory disorders, particularly autoimmune disorders, with the C-reactive protein raised due to any other inflammation, they have a higher chance of developing the migraine. Patients who have the other inflammatory disorders and the interleukins also raised, or these tumor necrotizing factors like alpha adhesion molecules, which also all the three, C-reactive protein, interleukins, and tumor necrotizing factors, these three are suggestive of some inflammatory pathology in the body, systemic inflammatory pathologies at different zones or different areas of the body or different tissue systems of the body. They can be the triggering factors for the migraine or predisposing factors of migraine. So any patient who has some inflammatory disorders of their body, it could be of anything like rheumatoid pathology, ulcerative colitis, and so on, they increase the risk of developing the migraine in such patients. Patients who have oxidative stress, who have thrombosis like conditions, again the patients, they tend to develop migraine more frequently. Increased body weight, obese patients, they have a high chance of developing migraine. High blood pressure, hypercholesterolemia, impaired insulin sensitivity, particularly diabetic patients who require a high dose of insulin, they have a high incidence of migraine. And homocysteine levels, hormonal changes. Patients who have stroke or coronary heart disease, they have a high chance of migraine as such. Certain of the study reports which suggests about some linkage of other conditions with the migraine. Study reports, they are very rather game-changing observations and very significant observations. So I have just copied the sentences from the relevant literature. Those who are interested, they may go through the whole of this literature, complete literature, and you will get a lot of significant information about the this relationship of the factors which trigger the migraine and such. And these are one, as per the Women's Health Society, the migraine with aura raise the risk of myocardial infarction. See, the issue is myocardial infarction may be considered as a triggering factor. Migraine with aura can be a cause for and trigger the myocardial infarction, and this coincidence seen in 91% and ischemic stroke by about 180%. So it increases the risk by 91% to 180%. So patients with migraine, they need to be evaluated for the myocardial pathologies and possibility of ischemic stroke, and some remedial measures may have to be taken to prevent this, and particularly in women. And with aura raise the both risk by approximately 20%. That's one of the important observations which has a lot of clinical relevance. Then compared with the men without a history of migraine, those who experienced migraine with aura had about 90% increase of risk of hypertension, while those experienced migraine without aura had about 21% increased risk. So migraine with the aura, the patient have a risk of hypertension, but migraine without aura, risk of hypertension is very high. Increased iron concentration is significantly related to the migraine. Patients who consume iron contents for the treatment of anemia, either with anemia or without anemia, which has become a fashion, like consumption of the iron containing drugs has become considered as a tonic, and that itself can be a cause for the migraine in majority of the patients. As far as the prognosis is concerned, because migraine is a very vague disease and the diagnosis also is vague, you will also have to predict upon the statistical analysis of the prognosis. Prognosis, as with all the contemporary treatment protocols, persons who had migraine during the childhood, 62% remained, they were free from migraine. They were free from migraine after 2 years. So majority of the patients of migraine, they would have only a duration, maybe around 1 to 2 years in the life, where the patient may have migraine, then it may subside without any specific treatment even. And those who, and particularly those who had in childhood, the migraine symptoms in childhood, majority of them, 62%, would be free from the symptoms after about 2 years. Whereas when it occurs in the middle age, later part, young adults, only 40% were free from the migraine at the age of 30 years. So it takes a longer time, and number of people who become free of migraine at the later half of life would be lesser. Severity and frequency of migraine attacks tend to diminish with increasing age. So, but though the chances of patients continuing to be migraineur are increased after the later age, but if the migraine occurs in the later age, the severity would be comparatively lesser, and number of attacks also could be lesser. And after 15 years of suffering migraines, approximately 30% of men and 40% of women no longer would have migraine attacks. So about in the later half of the life, migraine can persist for a longer duration, though the intensity becomes relatively milder. And that's about one of the important statistical data, which gives you a clear idea of efficacy of your treatment. When you treat the patients of migraine, the results can be compared to these results, and then you can say like whether whatever you do as the treatment is effective or not. Now, both male and female migrainists have 2.5-fold increase in the risk of subclinical cerebellar stroke, and cerebellar stroke, presenting with cerebellar stroke we have already discussed in the previous sessions, and where the patient may have symptoms like giddiness and inability to walk or difficulty in gait and so on, and headache frequency are also at a high risk as such. Then clinical presentation of migraine. Now this again is a very rather confusing issue. The whole clinical presentation of migraine can be quite atypical. A huge varieties of presentations can occur, but the most common and ideal clinical presentation is a patient would have attack of headache when the patient is awake. though the patient may have occasionally headache at sleep, but in general, a migraine diagnosis is made when the patient has a headache when he is awake. Uh, but at time, very rarely, it may awaken the patient at night. Then typically the headache lasts for 4 to 72 hours, and more than 2/3 of the patient attacks lasting longer than 24 hours. So only about 2/3 of the patients may have a prolonged duration as such. Then other neurological symptoms that may be observed are some of the patients may have hemiparesis like symptoms or aphasia, confusion, paresthesia or numbness, which give you some confusion with the stroke. So many of the patients are maybe intracranial pathologies. About 60% of the people who experience migraine report premonitory symptoms. They will have some symptoms before the onset of the headache, and these prodromal features, they are not again absolutely necessary to confirm the diagnosis of migraine, but when they are having the symptoms, then it may be helpful to make the diagnosis of migraine. And the common prodromal features, the symptoms which may occur before the patient have a headache, would be a increased sensitivity to light, sound or odors. Smell, light or sound may become intolerable to the patients. Lethargy or uncontrollable yawning. Patients have prior to that, a few hours before the onset of that headache symptoms, the patient may have these symptoms. Patient may have food cravings, a large, significantly huge appetite, and preference to take the food. Or mood changes, mental and mood changes like depression, anger or euphoria also could be preceding that attack of headache. Excessive thirst or polyuria. Patient may have a fluid retention, anorexia, constipation or diarrhea. These can be the prodromal features of a migraine as such. Some of the patients, as I told you, we categorize migraine into two categories of migraine with aura and migraine without aura. The aura, that's the symptom complex presented prior to the onset of the headache symptoms, could be the neurological symptoms which precede the headache or maybe occasionally accompany the headache. It usually develops over 5 to 20 minutes and can last maximum up to 60 minutes. And the aura are categorized into visual, sensory or motor or a combination of these. The visual symptoms are more common. Among those symptoms, visual symptoms are more common, and the visual symptoms may be presented as the field defects of vision. The patient may say that a patient is not able to see the whole area, or scotomas, central scotomas, tunnel vision, or visual defects related to the height, or complete blindness also can occur. To demonstrate that what could be the visual defects, some of the literature have picturized that visual defects which could occur during the migraine aura. It could be a field diminution, or it could be the scotomas, different central scotoma or multiple spots of scotoma which can occur, or maximum could be total blindness. So visual symptoms could occur. Then motor symptoms could be like loss of movement or reduced movement in certain part of the body can occur. The factors which trigger the migraine, patients often also say that the migraine could be triggered due to certain of the factors, and the factors which trigger the migraine are like hormonal changes, such as most of the common is menstruation, pregnancy or ovulation, and stress is one, like examination, so on, or excessive or insufficient sleep. Now medications, smoking, exposure to bright or fluorescent light, strong odors, head trauma, weather changes, motion sickness, cold stimulus or ice cream, etc., lack of exercise, fasting or skipping of the meals, red wine also is known to that. Now these precipitants which are mentioned in the current medical textbooks, they are exactly the reproduction of what Sushruta has mentioned, which I have referred to, that shloka which I have referred earlier. The causes of the headache mentioned in Samhita, they are almost the same which are mentioned as the migraine precipitants. Of course, the same migraine precipitants which are again presented in a typical manner, are classified manner, like related to the food, tea, tea, coffee also can trigger headache in certain patients. Most important among them is alcohol. What we see very frequently is alcohol being one of the triggering factors for the migraine. Then in the daily life patterns, weather changes and fasting and exhaustion and changes in the sleep pattern. These are very important. Of course, genetic factors, certain of the patients who have that abnormal genes, which may not be of much use in our regular clinical practice, that genes identification may not be a possible thing in the regular practice. But other important issues which are very strong, important from the clinical point of view are high insulin levels, free iron deposition, patients who are taking very high doses of insulin, patients who consume lots of iron containing substances, and the monosodium glutamate. Monosodium glutamate is the Ajinomoto, which is presented in many of these junk food like conditions. These are important, very frequently seen entities. Estrogen levels also are other factors. Then oxidative stress, metabolic derangements, changes in ovarian hormone secretion due to either contraceptive drugs, etc. Heavy metal and deviated enzyme levels also can be a cause for that. Now, because the migraine is a purely clinical diagnosis, to diagnose the migraine, there are different criteria now available. A lot of confusing areas are there. One of the most oldest method of consuming the maybe making the diagnosis of migraine was based upon a simple questionnaire, that's IDCM questionnaire, chronic migraine questionnaire, and that questionnaire would be mainly based upon 3 items. Do you feel nauseated or sick in your stomach during the headache? Did your headache limit you from working, studying, or doing what you needed to do for any day in the previous 3 months? Does light bother you a lot more than when you don't have headaches? Now, for these 3 questions, if the answer is yes for more than 2, it could be considered as a migraine. This was our old method which we used to follow in the earlier days of clinical practice. But now there is a big modification. Lots of modifications are there made in the criteria of making the diagnosis of migraine. The latest is the 12-item detection tool, where again there are 12 questions which are asked and if the question answer to these are positive, making that you will have the chart, objective confirmation of the diagnosis of migraine. This chart is available, so those who are interested in writing research, this thesis on migraine, they now have to follow these charts as like the frequency of the headache is the questionnaire about the frequency of the headache, and the scores are put in, and based upon the scores you can make out the diagnosis of headache. Of course, these are basically the same 3 questionnaire, but the 3 questionnaire is given a certain more additional detail and converted into a 12 questions detail as such. But International Headache Society, it has made a final and a current, rather the common method of making the diagnosis of migraine is if the patient had 5 or more episodic headaches lasting for 4 to 72 hours. So from the current methodology point of view, to make a diagnosis, patient should have at least 5 or more episodes of headache which had lasted for 4 to 72 hours. And if any of the 2 of the following were seen during the headache, like unilateral, it's limited to one side of the headache, throbbing or pulsating type, and worsened by movement, moderate or severity in the intensity, plus either the patient has nausea or vomiting or phonophobia or photophobia. Phonophobia is aggravation due to the sounds or aggravation due to the light. If these combinations are there, then you can make the diagnosis of migraine. So the latest diagnosis of migraine is based upon the IHS model, and that IHS criteria is there should be at least 5 or more episodes of headache earlier before you make the diagnosis. You will not make the diagnosis in a first episode, and the first episode of a headache, it requires some elaborate investigations to rule out the other conditions. Then it should also have the other criteria, at least either 2 of these, like either unilateral location, or the headache should be of throbbing or pulsating nature, it should be worsened by movement, and it should be having very severe intensity, plus nausea or vomiting or phonophobia or photophobia. When these are there, then you make the diagnosis of migraine. That's how the diagnosis of migraine is made out. The diagnostic criteria of migraine, again, still more modification, more detailed modifications are done. Of course, it is the same. The ICD has given a diagnostic criteria of migraine, and to make the diagnosis of migraine without aura. Now, migraine, again, as we have told, they could be categorized into migraine without aura and with aura. There again, certain more modifications are done of the same IHS criteria. At least 5 attacks, one fulfilling the criteria B to D. That criteria B to D are the same. Headache attacks lasting for 4 to 72 hours. Headache has at least 2 of the following unilateral. It's almost the same as IHS, but slight modification. Unilateral location, pulsating quality, moderate to severe pain intensity, aggravation by causing avoidance of routine physical activity. Then D is during headache, at least one of these. This is exactly the same. So migraine without aura, the diagnosis is exactly same as that of the IHS criteria. And the only additional factor is not better accounted for by any other clinical diagnosis. Then migraine with aura, again it comes with the same, at least 2 attacks. So migraine with aura, the number of attacks required would be lesser if 2 attacks fulfilling criteria B or C, and there should be one episode of one or more of the following fully reversible aura. A reversible aura like visual aura, sensory or speech or motor or brainstem aura or retinal aura, where the patient may have that visual abnormalities, which is reversible. Important, aura is always reversible. A neurological deficit may not be reversible. So that's how it has to be made out. The patient may have these visual symptoms or sensory or speech symptoms prior to the episode, and it should be at least in one of the attacks it should be presented, or at least 3 of the following 6 characters. Those are at least one aura symptom spreads gradually over 5 minutes, or 2 or more aura symptoms occur in succession, one after the other, or each individual aura symptom lasts for 5 to 60 minutes, and at least one aura symptom is unilateral, and at least one aura symptom is positive, and the aura is accompanied or followed within 60 minutes by headache. So immediately after the aura, within 60 minutes the patient should have a headache. Then you may confirm that whatever the symptoms have occurred are the aura suggestive of the headache. And of course the last thing is not better accounted for other methods of diagnosis, other clinical methods of diagnosis. So for the diagnosis of migraine with aura, the number of episodes required are reduced to 2 instead of 5, and the aura symptoms and relationship of the aura with the headache, that time duration, are considered as a criteria to make the diagnosis of headache. The important differential diagnosis, a patient presenting with a headache, the most important differential diagnosis are space occupying lesions, cerebral venous thrombosis, spontaneous internal artery dissection, intracranial aneurysm, meningitis, which require elaborate investigations. We will be dealing with these conditions separately, but in due course of time when we discuss the neurological disorders. So there we will give more attention to space occupying lesion or venous thrombosis, etc. But in general, any of these symptoms, if the patient has very severe headache with sudden and explosive onset, which never had that previous history, first episode of a very severe headache with sudden onset, or if the patient has a stiff neck, if the patient has photophobia, if the patient has nausea and vomiting, and in general, majority of the patients, there could be a slight reduction of the symptom of headache after the vomiting. If the vomiting doesn't relieve the headache, and if the patient may have alteration of consciousness or the localized neurological signs, then that patient requires immediate attention. The patient requires elaborate investigations, and these symptoms could be suggestive of any of these differential diagnosis conditions. That's very important. So a patient coming to you with a headache, first episode of headache, is always high risky. You need to go for the investigations elaborate, and then only make out the rule out the other conditions. Patients who have a long history of headaches where the episodes are more than 5 or so, you may make the diagnosis of migraine safely based upon that migraine criteria. That's the important thing. In addition to these, the other common conditions which can mimic migraine, but they are not characterized migraine and may have presently headache would be crash migraine, exertional headache or coitus headache. After sexual indulgence, that's coitus headache. Crash migraine is due to trauma, headache produced trauma. Exertional headache after strain, if the patient develops headache, that also have to be differentiated. And particularly, as I told you, there is a repeated issue, which is very important clinically. Conditions which require thorough investigations, like the first worst headache in the patient's life, and if the patient has a very rapid onset, and a change in the frequency, severity or clinical features of the headache. If the patient had relatively a different sort of the headache earlier, now the pattern of the headache is changed now, again that requires investigations. And new headache which persists for days, it requires thorough investigation. Precipitation of headache with the vessels manner, like coughing, sneezing, bearing down, which usually suggests of sinusitis, involvement of the sinuses, that needs investigation. Then presence of neurological signs and symptoms like diplopia, loss of sensation, weakness, that again requires investigations. Onset of headache after the age of 55 years, you have to have the investigations. Headache developing after head injury or major trauma. Persistent one-sided throbbing headaches. Headache accompanied by stiff neck or fever. Atypical history or unusual character that does not fulfill the criteria of migraine. If the patient has a history of episode of headache, but it doesn't fulfill the criteria of migraine. And if the patient has not responded to the optimal therapy of migraine, this require investigation. So the guideline in the migraine management given is the conditions which require thorough investigations. Important. These are all very important, crucial from the clinical point of view. When a patient presents with a symptom of headache, it's quite important to rule out migraine, and because the migraine is a purely clinical diagnosis, no objective investigations are confirmatory or no objective evidences are possible. You have to take all the care to rule out the other conditions. So once you have made the diagnosis of migraine, the treatment overview protocol would be, the first is you have to diagnose the migraine, which itself is an elaborate job and which we have already discussed. Then assess the disability. There is no curative or absolute curative treatment there. So you need to educate the patient about the possible course of the migraine and possible consequences. Certain of the management has to be individual. There cannot be a one straight jacket management, and the care has to be taken as per the patient's condition. And the migraine specific treatment and analgesia, there are two aspects. One is when the patient presents with the headache, the symptom of pain has to be reduced, and the other is the migraine specific treatment. The migraine specific treatments are mainly of these categories. Now I will not go into much details about these issues, but basic idea of the patients coming to you with these drugs, you should have an idea like what are those drugs and what their uses or limitations. Serotonin agonists, dietams, selective serotonin receptor agonists like triptans. These are the very commonly prescribed drugs. Then calcitonin related receptors. These are new drugs, more costly, and like remipagent, which is very costly drug and recently used. Like ergot alkaloids, they are the oldest of the drugs used in migraine. Earlier prescription. The current doctors prescribe either triptans are more frequently prescribed in India. Ergot alkaloids, ergotamine now has become almost obsolete like among practitioners, but still there are conditions which respond only to ergot alkaloids. Then analgesics, any of the common analgesics are non-steroidal inflammatory drugs. These are common symptomatic drugs. Now there are many products which are available in the market as combination drugs. Antiemetics also may have a role to play in case of this migraine management. The standard prescription levels would be, which is based upon the International Headache Society recommendation, recent IHS recommendation, would be if the patient has a moderate symptom, NSAIDs or isomethertine or ergotamine and triptans. These are to be prescribed. Severe, then you have to go for the CGRP drugs like nezarpine or rizatriptan or sumatriptan. These are rarely prescribed in India. Extremely severe. Now this is again important. Extremely severe, again ergotamine is the drug. Dihydroergotamine, opioids or dopamine antagonists are used. Among the triptans which are used, these are the drugs which are available. Sumatriptan, rizatriptan, these are the different brands of them. Not much of a difference in the outcome, only the issue is about the cost. Then among the calcitonin gene related peptide antagonists which are used in India quite frequently are Zargepant, Intransal. Then of course the antiemetics also have a role to play in as a symptomatic treatment. Then as far as the migraine prophylaxis therapy, the most common used prophylactic drugs are 5-HT2 block antagonism like methotrexate. Now I refer to these issues because many of the patients come to you with these prescriptions. So what to do with the prescriptions? You should know about that. That from that point of view, these are all important issues. And the calcium channel blockers also are used as prophylaxis. And central neurotransmitters blocking or modulation by beta blockers or tricyclic antidepressants, very common prescriptions. Majority of the patients who come to you with the history of migraine, they are using these drugs as a prophylaxis. And GABAergic drugs, valproic acid, anti-epileptic also, they could be used as a prophylaxis. And botulinum toxin also is rarely prescribed for blocking the presynaptic membrane, and CGRP inhibitors also are used. Among the practically clinical conditions, majority of the patients who come to you, they come with beta blockers or tricyclic antidepressants as the prescription for prophylaxis. And in a patient who is being treated by our treatment, we should not stop these drugs immediately. Only after the patient has a satisfactory relief, these should be stopped. Whereas the other drugs like valproic acid or methotrexate, they can be stopped somewhat easily. Most of the patients of migraine, they may have other comorbid conditions, which is very important. The patient of migraine, you need to assess the patient's other conditions, which may require some of the treatment, and those treatments should not be again withdrawn. So most common comorbid conditions are hypertension, angina, stress, depression, psychiatric conditions, overweight or underweight, epilepsy, mania. And in these conditions, whether these drugs should be stopped or should be continued, again is a very complex issue which requires a lot of clinical assessment. That's what I said, like the treatment has to be custom made, individualized. There cannot be a specified management. That's about the principles of the management from the current point. Now, cluster headache is another modification, alteration of the migraine. Now, whether cluster headache has to be considered as a migraine or a different issue, there is a difference of opinion. But as per the International Headache Society, it has considered this as a variant of migraine. And the definition of cluster headache as per the IHS is a patient experiences attacks of severe or very severe, strictly unilateral pain related to orbital or supraorbital or temporal area, lasts for about short duration of 15 to 180 minutes, and occur from once every other day or 8 times in a day. The frequency could be more, very frequently in a day, or at a short duration it occurs, but the total duration of the attack also is shorter. It's 15 minutes, 180 minutes. And the attacks are associated with any one of the following, like conjunctival injection, reddish discoloration of the eyes, conjunctiva, lacrimation, nasal congestion, rhinorrhea, forehead or facial sweating, meiosis, ptosis or eyelid edema. If these are there, then that's considered as a cluster headache. The pictorial definition of pictorial description of aura, cluster headache and migraine with aura would be: the cluster headache would occur a sudden episode, short duration, then there is a big gap, and then again there could be episode. Migraine can occur at regular intervals with an aura and then an episode of migraine, one episode, no such repeated episodes. This is how the frequency is described of cluster headache. Incidence of cluster headache is more common in male sex and ages of older than 30 years, and patients who have a habit of consumption of vasodilators like alcohol, previous head trauma or surgery also can be a cause for cluster headache. And histamine provokes cluster headaches in 69% of the patients. Stress, allergens, seasonal changes, nitroglycerin also may trigger attacks in some patients. Alcohol induces attacks during a cluster but not during remission. Attacks can aggravate if the patient consumes alcohol, and about 80% of the cluster attack patients are heavy smokers and 50% are heavy or ethanol users, alcohol users as such. But this also is considered as a variant of the migraine only. The character of cluster headache is excruciating, stabbing, sharp, and severe acute pain where the patient is feeling as if the eyes are pushed out rather than throbbing type of headache, and essentially unilateral and limited to periorbital or retroorbital area. And the first and second division of the trigeminal nerve area are usually involved in 18 to 20%, and often this is also diagnosed as a trigeminal neuralgia. Basic difference between the trigeminal neuralgia and the cluster headache we will discuss later on when we discuss the trigeminal neuralgia. And it may even spread to the back of the neck along the carotid artery. Characteristically, onset is sudden and peaking in 10 to 15 minutes. Duration 5 minutes to 3 hours maximum. And frequency may occur 1 to 8 times a day as long as about 4 months. Often it can also occur at night time. It very often occurs at night time, unlike that of a typical migraine. It may have a circadian regularity in 47%. Remission, long symptoms and free intervals occur in some patients, and the remissions may average for about 2 years from 2 months. The eye signs in the cluster headache are important. Same, it's repetition, lacrimation or conjunctival injection, nasal stuffiness, ipsilateral eyelid edema or meiosis or ptosis, and forehead and facial perspiration, sweating. This occurs in a good number of patients. As far as the treatment protocol is concerned, primarily the treatment protocol is the same as that of the migraine. The other variants or additional factors could be like oxygen given at 8 liters per minute for 10 minutes in 100% with the mask may help in reduction of the headache immediately, which is, if it is used early, the headache can be relieved immediately. Corticosteroids are extremely effective in terminating the headache cycle. Cluster headache cycle can be terminated. These are not the long-term treatment. These are to treat that acute episode of a cluster headache. Then 5-HT receptor agonists such as triptans or ergot alkaloids are also considered as the first line of treatment, as the same as that of the migraine. Then calcium channel blockers may be effective in reducing the headache or preventing the headache prophylaxis. As far as the Ayurvedic treatment for these migraine and migraine variants with aura, the typical presentation of migraine mentioned is the Suryavarta, where Suryodayam yaprati mandamandam akshibhruvam luk samapayiti gadaha vivarditeja amshimada sahiva Suryapurvata vinivartateja. Those headaches tend to occur during the awakened time and relatively lesser at the night time, one of the features of the typical migraine. And the ideal treatment which I do prescribe and which gives a more effective treatment than the other contemporary triptans and so on would be Smithsagara, Kamadaga and Pathyadikada, which I generally prescribe, and the patients would have a significant relief among that. So migraine looked at from Ayurvedic point of view from a slightly different view as such compared to what the contemporary science is. And the Anantavata is one more variety of the migraine where the patient may have a neurological deficit. Doshas sustaha trayo manyam sampitya ghata sujam sutivram kurvantiyo akshibhrve shankar deshe sthitam karotyashu visheshvastu gandasya parshvet karoti kampam hanugraham lotyadanashyogan Anantavam. So where the patient has some neurological deficits as a presenting signs, or maybe the aura which is presented. In that condition, the ideal treatment would be Smithsagaras, Ekangara, Sarasvarishta, Tailadhara or Natravasya also may require, and these patients may require prolonged treatment, and many times the results may not be very ideal as such. Then another of the variants of the migraine which we see quite frequently would be Rukshashana, Adhyashana, Pragbata, Avashya Maithune, Vegasaklaranayaasa, Vyayame, Kupito Anilaha, केवलः सकफो वा अर्धं गृहीत्वा शिरसोपरि मन्या भ्रू शंक कर्णाक्ष ललाटार्जे अतिवेदनं शस्त्र अरणिर्भं कुर्यात् तीव्रं सो अर्धावभेदकः नयनं वा अथवा श्रोत्रम् अतिवृद्ध विनाशयेत्. Ardhavabhetaka is another of the condition where it is limited to the one side, the typical cluster headache, or maybe slight modification of the cluster headache, a migraine with the clinical signs of the eyes as such or throbbing pain, the preferable treatment would be where the kapha lakshanas, nasal discharges also are presented. Mrityunjaya, Sutushikara and Anutelanasya helps as such. The cluster headache is presented as the Shankhaka by Sushruta. रक्तपित्तानिलाहुष्टा शंखदेशे विमूर्छिताः तीव्ररूपाः रागमुहि शोथं कुर्वन्ति दारुणं सशिरो विषवद्वेगी निरुन्ध्य आशु दलं तथा त्रिराजीवितं हन्ति शङ्खको नामतः परं त्रयः वैषज्यं प्रत्याख्याय समासे. That Shankhaka, either it could be the cluster headache or it could be the space occupying lesion. So space occupying lesions have to be ruled out, or maybe the acute conditions like venous thrombosis, it can become fatal, they have to be ruled out. So Shankhaka may have both these. If you have ruled out that, then I would consider Shankhaka as the cluster headache, and the cluster headache, the management of acute condition may require either glucocorticoids or other drugs, maybe analgesics also may be required. I don't say that acute cluster headache can be managed effectively with our treatment, but patients with episodes of cluster headache can be effectively treated, and episodes can be prevented or reduced with the Smithsagarasa, Kamahuda, Saraswarishta and Tailadhara or Matrapasti. And the last, of course, patients of migraine may require hospital admission if the patients have very severe nausea or vomiting or hence dehydration, or if the patients have very severe status of migrainosus, like persistent headache can occur, and if the patients have other history of other drugs which have triggered the migraine, they may require treatment for detoxification like Virajana. This is how the total treatment of migraine is done. With this, we will conclude today, and next we will take up other issues related to the neurological conditions. If there are any questions, we will answer that and then wind up. There is one question. Matra Basti by which oil could you suggest, and Basti protocol for continue for 8 days or weekly? So usually we give that 7 days Yoga Basti, and the usually I would prefer is Balataila for Matra Basti usually. Maybe in certain conditions we may just modify Ashwagandha Taila also, maybe occasionally, but majority of the patients is the Bala Taila which is used for Matra Basti, and Yoga Basti. 7 Bastis is the usual course which we do there. Right? No more questions. So we will wind up today.